All right, Chapter 18, Care of Postoperative Patients by Robin Shard. Learning Outcomes. For clinical competence and success on the NCLEX examination, study this chapter with these learning objectives in mind. Safe and effective care environment. Apply concepts of sterile technique, asepsis, and standard precautions during wound assessment and dressing changes. 2. Use special agency criteria for determining readiness of the patient to be discharged from the post-anesthesia care unit, or PECU. Care promotion and maintenance. 3. Evaluate patient risk for complications of wound healing. 4. Provide postoperative education for patients and family members after surgery. Physiological integrity. Perform an ongoing head-to-toe assessment of the postoperative patient. Prioritize nursing interventions for the patient recovering from surgery and anesthesia during the first 24 hours. Apply knowledge of pathophysiology to monitor the patient for the complications of shock, respiratory depression, and impaired wound healing after surgery. 8. Assess the patient's level of postoperative pain and evaluate his or her responses to coordinate pain management strategies and interventions. 9. Explain the actions, dosages, side effects, and nursing implications for different types of drug therapy for pain management after surgery. 10. Evaluate surgical incisions and wounds for complications. And 11. Collaborate with healthcare team members to perform emergency care procedures for surgical wound dehiscence or wound evisceration. Okay, here's the text. The postoperative period starts at the completion of surgery and transfer of the patient to either the post-anesthesia care unit or PACU, the same-day surgery SDS unit, or the ambulatory care unit, or the intensive care unit, the ICU. Discharge from these areas is based on the stability of the patient and the meeting of special discharge criteria. Many patients can be discharged to home shortly after surgery is completed. They are observed and monitored until discharge criteria are met and are then discharged. Some patients move from the specialized nursing care in the PACU to a hospital inpatient floor on ICU for additional nursing care. The postoperative period continues after the patient's condition is stabilized, as well as after the patient is discharged from the ambulatory surgery facility or hospital. The actual time spent away from home after surgery varies according to age, physical health, self-care ability, support systems, type and length of surgical procedure, anesthesia, any complications, and community resources. Overview. The purpose of post-anesthesia care unit or PACU recovery room is the ongoing evaluation and stabilization of patients to anticipate, prevent, and treat complications after surgery. The PACU is usually located close to the surgical suite for ease of access and patient transfer. The unit is usually a large and open room to provide best observation of all patients and easy access to supplies and emergency equipment. Adults are usually separated from children. The patient area may be divided into individual cubicles so that each patient can be observed continuously. Privacy curtains or screens are closed only during bedside procedures. Each cubicle has equipment to monitor and care for the patient, such as oxygen, suction equipment, cardiac monitors, pulse oximetry, airway equipment, and emergency drugs. After the surgery is completed, the circulating nurse and the anesthesia provider accompany the patient to the PACU. When the patient is in critical condition, transfer may be directly from the operating room to the ICU. On arrival, the anesthesia provider and the circulating nurse give the PACU nurse a verbal handoff report to communicate the patient's condition and care needs. A handoff report that meets National Patient Safety Goal 2 requires effective communication between healthcare professionals. It is at least a two-way verbal interaction between the professional giving the report and the nurse receiving it. The language used by the person or persons giving the report is clear and cannot be interpreted in more than one way. The nurse receiving the report focuses on the report and is not distracted by the environment or other responsibilities. Standardizing the information reported helps prevent omission of critical patient-centered information that helps avoid irrelevant details. The receiving nurse takes the time to restate or report back the information to verify what was said and to make certain that both the reporting professional and the receiving nurse have the same understanding. The receiving nurse takes the time to ask questions, and the reporting professional must respond to the questions until a common understanding is established. Chart 18.1. Chart 18.1 gives an example of critical information to include in a standard handoff report. The PACU nurse is skilled in the care of patients with multiple medical and surgical problems immediately after a surgical procedure. This area requires in-depth knowledge of anatomy and physiology, anesthetic agents, pharmacology, pain management, extubation, and surgical procedures. The PACU nurse is skilled in assessment and can make quick decisions if emergencies or complications occur. The patient is monitored closely. The anesthesia provider and surgeon are consulted as needed. Patient-centered collaborative care. Assessment. History. Use the surgical team's report to plan the care for an individual patient. After receiving the report and assessing the patient, review the medical record for information about the patient's history, pre-surgical, physical condition, and emotional status. If the patient remains as an inpatient, the surgical and anesthesia information is incorporated into the post-operative plan of care. Chapter 16 identifies situations that increase the patient's risk for potential complications, listed in Table 18.1. Physical assessment / clinical manifestations. Assess the patient and record data on a PACU flowchart record, Figure 18.1. Assessment data include level of consciousness, temperature, pulse, respirations, oxygen sat, and blood pressure. The most important assessment is respiratory. Examine the surgical area for bleeding. Monitor vital signs as often as your facility's policy states, the patient's condition warrants, and the surgeon prescribes. Once the patient is discharged from the PACU, vital signs are often measured every 15 minutes for 4 hours. I'll say that again. Once the patient is discharged from the PACU, vital signs are often measured every 15 minutes for 4 times, every 30 minutes for 4 times, every 2 hours for 4 times, and every 4 hours for 24 to 48 hours if the patient's condition is stable. Therefore, if the patient is admitted, vital signs are assessed according to the facility's policy, the patient's condition, and the nurse's judgment. The healthcare team determines the patient's readiness for discharge from the PACU by the presence of a recovery score rating or at least 10 on the recovery scale, see Figure 18.1. Other criteria for discharge, e.g. stable vital signs, normal body temperature, no overt bleeding, return of gag, cough, and swallow reflexes, and the ability to take liquids, may be specific to the facility. After you determine all the criteria have been met, the patient is discharged by the anesthesia provider to the hospital unit or to home. If an anesthesia provider has not been involved, which may be the case with local anesthesia or conscious sedation, the surgeon or nurse discharges the patient once the discharge criteria have been met. Chart 18.1, Best Practice for Patient Safety and Quality Care. Postoperative handoff report. Type and extent of the surgical procedure, type of anesthesia and length of time the patient was under anesthesia, tolerance of anesthesia and the surgical procedure, allergies, especially to latex or drugs, pathologic condition, oxygen saturation, status of vital signs, core body temperature, type and amount of IV fluids and drugs administered, estimated blood loss, or EBL, any intraoperative complications such as a traumatic intubation, preoperative drugs and patient responses, primary language, any sensory impairments, any communication difficulties, anxiety level before receiving anesthesia, special requests that were verbalized by the patient preoperatively, preoperative and intraoperative respiratory function and dysfunction, pertinent medical history, including substance abuse, location and type of incisions, dressings, catheters, tubes, drains, or packing, intake and output, including current IV fluid administration and an estimated blood loss, prosthetic devices, joint or limb immobility while in the operating room, especially in the older patient, other intraoperative positioning that may be relevant in the postoperative phase, intraoperative complications, how managed, patient responses, any other important intraoperative occurrences. Assessment continues from the PACU to the intensive care or medical surgical nursing unit. If the patient is to be discharged from the PACU to home, assessment is continued by home care nurses or by the patient or family members after health teaching. When the patient is transferred to an inpatient unit, complete an initial assessment on arrival, chart 18.2. During the postoperative period, all patients remain at risk for pneumonia, shock, cardiac arrest, respiratory arrest, deep vein thrombosis, GI bleeding. These serious complications can be prevented or the consequences reduced with coordinated care. Nursing observations and interventions are part of critical rescue management for patient safety and quality care to reduce the risk for an adverse patient outcome after surgery. Respiratory system. When the patient is admitted to the PACU, immediately assess for a patient airway and adequate gas exchange. Although some patients may be awake and able to speak, talking is not a good indicator of adequate gas exchange. An artificial airway, such as an endotracheal tube, a nasal trumpet, or nasal trumpet was kind of funny, or an oral airway may be in place. If the patient is receiving oxygen, document the type of delivery device and the concentration or liter flow of the oxygen. Continuously monitor pulse oximetry for oxygen saturation, SpO2, while the patient is in the PACU. The SpO2 should be above 95% or the patient's pre-surgery baseline. If it drops below this level, notify the surgeon or anesthesia provider. If it drops by 10 percentage points and you are certain it is an accurate measure, call the rapid response team. Table 18.1, General Potential Complications of Surgery. Respiratory system complications: atelectasis, pneumonia, pulmonary embolism or PE, laryngeal edema, ventilator dependence, and pulmonary edema. Cardiovascular complications: hypertension, hypotension, hypovolemic shock, dysrhythmias, deep vein thrombosis or DVT, heart failure, sepsis, disseminated intravascular coagulation or DIC, anemia, and anaphylaxis. Skin complications: pressure ulcers, wound infection, wound dehiscence, wound evisceration, skin rashes, contact allergies. Gastrointestinal complications: paralytic ileus, gastrointestinal ulcers and bleeding. Neuromuscular complications: hypothermia, hyperthermia, nerve damage and paralysis, joint contractures. Renal-urinary complications: urinary tract infection, acute urinary retention, electrolyte imbalances, and renal failure. Back to the text. Assess the rate, pattern, and depth of breathing to determine adequacy of air exchange. A respiratory rate of less than 10 breaths per minute may indicate anesthetic or opioid analgesic-induced depression. Rapid, shallow respirations may signal shock, cardiac problems, increased metabolic rate, or pain. Listen to the lungs over all lung fields to assess breath sounds. Also check symmetry of breath sounds and chest movement. If, for example, the patient has an ET tube, it could move down into the right mainstream bronchus and prevent left lung expansion. In this case, lung sounds on the left are absent or decreased, and only the right chest wall rises and falls with breathing. Okay, perform ongoing inspection of the chest wall for accessory muscle use, sternal retraction, and diaphragmatic breathing. These signs could indicate an excessive anesthetic effect, airway obstruction, or paralysis, which could result in hypoxia. Listen for snoring and stridor, a high-pitched crowing sound. Snoring and stridor occur with airway obstruction resulting from tracheal or laryngeal spasm or edema, mucus in the airway, or blockage of the airway from edema or tongue relaxation. When neuromuscular blocking agents are retained, the patient has muscle weakness, which could affect gas exchange. Indicators of muscle weakness include the inability to maintain a head lift, weak hand grasps, and an abdominal breathing pattern. If the patient returns to an inpatient unit, complete an initial assessment on arrival. See Chart 18.2. And then continue to assess for respiratory depression or hypoxemia. Listen to the lungs to check for effective expansion and for abnormal breath sounds. Check the lungs at least every 4 hours during the first 24 hours after surgery, and then every 8 hours or more often, as indicated. Older patients, smokers, and patients with a history of lung disease are at greater risk for respiratory complications after surgery and need more frequent assessment. Obese patients are also at high risk for respiratory complications. Cardiovascular system. Vital signs and heart sounds are assessed on admission to the PACU and then at least every 15 minutes until the patient's condition is stable. Automated blood pressure cuffs and cardiac monitoring assist in continuous assessment. Review vital signs after surgery for trends and compare them with those taken before surgery. Report blood pressure changes that are 25% higher or lower than the values obtained before the surgery. 15 to 20 point difference, systolic or dystolic. Report those to the anesthesia provider or the surgeon. Decreased blood pressure and pulse pressure and abnormal heart sounds indicate possible cardiac depression. Fluid volume deficit, shock, hemorrhage, or the effects of drugs. See Chapter 13 and 39. Bradycardia could indicate an anesthesia effect or hypothermia. Older patients are at risk for hypothermia because of age-related changes in the hypothalamus, the temperature regulation center. Low levels of body fat and coolness of the OR suite also may cause hypothermia. An increased pulse rate could indicate hemorrhage, shock, or pain. Cardiac monitoring is maintained until the patient is discharged from the PACU. For patients at risk for dysrhythmias, monitoring may continue either on telemetry units or on general medical surgical units. In assessing the vital signs of a patient who is not being monitored continuously, compare the rate, rhythm, and quality of the apical pulse with the rate, rhythm, and quality of peripheral pulse, such as the radial pulse. A pulse deficit, a difference between the apical and peripheral pulses, could indicate a dysrhythmia. Table 18.2, immediate postoperative neurologic assessment. Return to preoperative level. Order of return to consciousness after general anesthesia. 1. Muscular irritability. 2. Restlessness and delirium. 3. Recognition of pain. 4. Ability to reason and control behavior. Order of return of motor and sensory function after local or regional anesthesia. 1. Sense of touch. 2. Sense of pain. 3. Sense of warmth. 4. Sense of cold. 5. Ability to move. Chart 18.2. Focused assessment. The patient on arrival at the medical surgical unit after discharge from the post-anesthesia care unit. Airway. Is it patent? Is the neck in proper alignment? Breathing. What is the quality and pattern of the breathing? What is the respiratory rate and depth? Is the patient receiving oxygen? At what setting? What is the pulse oximetry result? Mental status. Is the patient awake or to be aroused? Oriented and aware? Or able to be aroused. Yeah. Does the patient respond to verbal stimuli? Surgical incision site. How is it dressed? Mark the amount of drainage on the dressing immediately. Is there any bleeding or drainage under the patient? Are any drains present? Are the drains set properly, e.g. compressed if they should be compressed, not kinked, patient not lying on them? How much drainage is present in the drainage container? Temperature, pulse, and blood pressure. Are these values within the patient's baseline range? Are these values significantly different from when the patient was in the post-anesthesia care unit or PECU? Intravenous fluids. What type of solution is infusing and with what additives? How much solution was remaining on arrival? How much solution infused in the transport time from PECU? At what rate is the infusion supposed to be set? Is it? Other tubes. Is there a nasogastric or other intestinal tube? What is the color, consistency, and amount of drainage? Is suction applied to the tube if ordered? Is the suction setting correct? Is there a Foley catheter? Is the Foley draining properly? What is the color, clarity, and volume of urine output? Peripheral vascular assessment needs to be performed because anesthesia and positioning during surgery, e.g. the lithotomy position for genitourinary positions or legs up in stirrups, may impair the peripheral circulation and contribute to deep vein thrombosis or DVT. Compare distal pulses on both feet for the quality of pulsation. Observe the color and temperature of extremities. Evaluate sensation and determine the speed of capillary refill. Palpable pedal pulses indicate adequate circulation and perfusion of the legs. Assess the feet and legs for redness, pain, warmth, and swelling, which may occur with DVT. Foot and leg assessment may be performed once during a nursing shift, once daily, or once per visit, depending on the patient's risk for complications and the facility's or agency's policy. See Chapter 16 and 38 for more information on DVT. Neurologic system. Cerebral functioning and the level of consciousness of awareness must be assessed in all patients who have received general anesthesia, Table 18.2, or any type of sedation. Observe for lethargy, restlessness, or irritability, and test coherence and orientation. Determine awareness by observing responses to calling the patient's name, touching the patient, and giving simple commands such as open your eyes and take a deep breath. Eye opening is in response to a command indicates wakefulness or arousability, but not necessarily awareness. Determine the degree of orientation to person, place, and time by asking the conscious patient to answer questions such as, what is your name? That would be person. Where are you? Be place. And what day is it? Be time. Neurologic system. Cerebral functioning and the level of consciousness or awareness must be assessed in all patients who have received general anesthesia, Table 18.2, or any type of sedation. Observe for lethargy, restlessness, or irritability, and test coherence and orientation. Determine awareness by observing responses to calling the patient's name, touching the patient, and giving simple commands such as open your eyes and take a deep breath. Eye opening is a response to a command. It indicates wakefulness or arousability, but not necessarily awareness. Determine the degree of orientation to person, place, and time by asking the conscious patient to answer questions such as, what is your name? Person, where are you? Place, and what day is it? Time. I think I read that already. Sorry. Considerations for older adults. For an older adult, a rapid return to his or her level of orientation before surgery may not be realistic. Preoperative drugs and anesthetics often delay the older patient's return to orientation. See Chapter 16 and 17. Compare the patient's baseline neurologic status obtained before surgery with the findings after surgery. Patients who had altered cerebral functioning before surgery as a result of another condition usually continue to have that alteration after surgery. After the patient is alert and all other criteria have been met, he or she is discharged from the PACU. On the medical surgical nursing unit, assess the level of consciousness every 4 to 8 hours or as indicated by the patient's condition and the facility's policy. Monitor function and sensory function are assessed for all patients who received general or regional anesthesia. General anesthesia depresses all voluntary motor function. Regional anesthesia alters the motor and sensory function of only part of the body. See Chapter 17 for more information on anesthesia. Motor and sensory assessments are very important after epidural or spinal anesthesia. Evaluate motor function by asking the patient to move each extremity. The patient who had epidural or spinal anesthesia remains in the PECU until sensory function or feeling and voluntary motor movement of the legs have returned. See Table 18.2. Also assess the strength of each limb and compare the results on both sides. Test for the return of sympathetic nervous system tone by gradually elevating the patient's head and monitoring for hypotension. Begin this evaluation after the patient's sensation has returned to at least the spinal dermatome level of T10. See Chapter 43 for further neurologic assessment. After the patient is transferred to the nursing unit, continue neurologic assessment as indicated. Fluid, electrolyte, and acid-base balance. Fasting before and during surgery, the loss of fluid during the procedure, and the type and amount of blood or fluid given affect the patient's fluid and electrolyte balance after surgery. Fluid volume deficit or fluid volume overload may occur after surgery. Sodium, potassium, chloride, and calcium imbalances also may result, as may changes in other electrolyte levels. Fluid and electrolyte balances occur more often in older or debilitated patients and in those with health problems such as diabetes mellitus, Crohn's disease, or heart failure. Intake and output measurements is part of the operative record and is reported by the circulating nurse to the PACU nurse. Record record any intake or output, including IV fluid intake, vomitus, urine, wound drainage, and nasogastric or NG tube drainage. You must know the total intake and output from both the OR and the PACU to assess fluid balance accurately and to complete the 24-hour intake and output record. Hydration status is assessed in the PACU and the medical surgical unit. To determine hydration status, inspect the color and moisture of mucous membranes, the turgor, texture, and tenting of the skin. Test over the sternum or forehead of an older patient. The amount of drainage on dressings, and the presence of axillary sweat. Measure and compare total output, e.g. NG tube drainage, urine output, wound drainage, with total intake to identify a possible fluid imbalance. Consider insensible fluid loss, such as sweat, when receiving total output. Continue to assess intake and output as long as the patient is at risk for fluid imbalances. Some facilities require intake and output to be measured if the patient receives IV fluids or has a catheter, drains, or an NG tube. In addition, patients who have heart disease or kidney disease may need a longer period of intake and output measurement. IV fluids are closely monitored to promote fluid and electrolyte balance. Isotonic solutions such as lactated ringers, LR, 0.9% saline, and 5% dextrose with lactated ringers, D5 over LR, are used for IV fluid replacement in the PACU. After the patient returns to the medical surgical unit, the type and rate of IV infusions are based on need. A typical IV solution for the patient being admitted to the nursing unit is 5% dextrose with 0.45% normal saline, or D5, 0.45% NS. See Chapter 13 and 15 for further discussion of IV fluids, electrolyte balance, and hydration assessment. Acid-base balance is affected by the patient's respiratory status before and during surgery. Metabolic changes during surgery and losses of acids or bases in drainage. For example, NG tube drainage or vomitus causes a loss of hydrochloric acid and leads to metabolic alkalosis. Examine arterial blood gas values and other laboratory values. See Chapter 14 for more detailed information on acid-base imbalances. Renal urinary system. Control of urination may return immediately after surgery or may not return for hours after general or regional anesthesia. The effects of preoperative drugs, especially atropine, anesthetic agents, or manipulation during surgery can cause urine retention. Assess for urine retention by inspection, palpation, and percussion of the lower abdomen for bladder distension or by the use of a bladder scanner. See Chapter 68. Assessment may be difficult to perform after lower abdominal surgery. Urine retention is common early after surgery and requires intervention, such as intermittent or straight catheterization, to empty the bladder. When the patient has an indwelling urinary or Foley catheter, assess the urine for color, clarity, and amount. If the patient is voiding, assess the frequency, amount per void, and any symptoms. Urine output should be close to the total intake for a 24-hour period. Consider other sources of output, such as sweat, vomitus, or diarrhea stools. Report a urine output of less than 30 mils an hour, 240 mils per 8-hour nursing shift to the physician. Decreased urine output may indicate hypovolemia or renal complications. See Chapter 68 for renal urinary assessment. Gastrointestinal system. Nausea and vomiting are among the most common reactions after surgery. About 30% of patients who receive general anesthesia have some form of GI upset within the first 24 hours after surgery. Preventative drug therapy is effective in reducing the incidences. A drug often used is ondansetron or Zofran, a serotonin agonist. Patients with a history of motion sickness are more likely to develop nausea and vomiting after surgery. Obese patients may be at risk because many anesthetics are retained by fat cells and remain in the body longer. Abdominal surgery and the use of opioid analgesics reduce intestinal peristalsis after surgery. These problems increase the risk for prolonged nausea and vomiting after surgery. Nausea and vomiting can stress and irritate abdominal and GI wounds, increase intracranial pressure in patients who had head and neck surgery, elevate intraocular pressure in patients who had eye surgery, and increase the risk for aspiration. Assess the patient continuously for nausea and vomiting. Often patients have nausea as the head of the bed is raised early after surgery. This symptom may occur with or without dizziness. You can help reduce this distressing symptom by having the patient in a side-lying position before raising the head slowly. Intestinal peristalsis may be delayed because of long anesthesia time. The amount of bowel handling during surgery and opioid analgesic use. In the PACU and later on the medical surgical unit, assess for the return of peristalsis. Patients who have abdominal surgery often have decreased or no peristalsis for at least 24 hours. This problem may persist for several days for those who have GI surgery. Listen for bowel sounds in all 4 abdominal quadrants and at the umbilicus. If NG suction is being used, turn off the suction before listening to prevent mistaking the sound of the suction for bowel sounds. The presence of active bowel sounds usually indicates return to peristalsis. However, the absence of bowel sounds does not confirm a lack of peristalsis. The best indicator of intestinal activity is the passage of flatus or stool. The abdominal cramping along with distension denotes trapped non-moving gas, not peristalsis. Decreased peristalsis occurs in patients who have a paralytic ileus. The abdominal wall is distended and there is no movement of the intestinal wall. Assess for the manifestations of paralytic ileus: few or absent bowel sounds, a distended abdomen, abdominal discomfort, vomiting, no passage of flatus or stool. A nasogastric tube may be inserted during surgery to decompress and drain the stomach to promote GI rest, to allow the lower GI tract to heal, and to provide an enteral feeding route. It may also be used to monitor any gastric bleeding and to prevent intestinal obstruction. One of the most common tubes used is the Salem tube, or the Salem sump. The Salem sump is a double lumen tube with an air vent to keep the tube from grabbing the gastric mucosa. This feature allows easy drainage of the stomach and prevents mucosal damage. Less commonly used is the Levin tube, which is a single lumen tube with no air vent. To promote drainage, suction, usually low, is applied to the NG tube. Suction is either continuous, recommended for the Salem sump, or intermittent. Record the color, consistency, and amount of the drainage every 8 hours, Table 18.3. In some instances, an occult blood test, or gastrocult, may be performed. Normal NG drainage fluid is greenish yellow. Red drainage fluid indicates active bleeding, and brown liquid or drainage with a coffee ground appearance indicates old bleeding. Assess that the NG tube is securely taped to the nose and note any skin irritation. Assess the patient for complications related to NG tube use, such as fluid and electrolyte imbalances, aspiration, and Nares discomfort. To prevent aspiration, check the tube placement every 4 to 8 hours and before instilling any liquid into the tube. See Chapter 58 for more information on tube placement and care. After gastric surgery, do not move or irritate the tube without an order from the surgeon. Fluid and electrolyte imbalances can result from NG drainage and tube irrigation with water instead of saline. Imbalances include fluid volume deficit, hypokalemia, and hyponatremia. See Chapter 13. Hypochloremia and metabolic acidosis. See Chapter 14. Alkalosis. Metabolic alkalosis, I think. Okay. Constipation may occur after surgery as a result. Constipation may occur after surgery as a result of anesthesia, analgesia, especially opioid analgesics, decreased activity, and decreased oral intake. Assess the abdomen by inspection, auscultation, palpation, and percussion, and record the elimination pattern to determine whether interventions are needed. For abdominal assessment, auscultate before palpation or percussion because these two maneuvers can affect peristalsis. Increase dietary fiber intake. The use of mild laxatives or bulk forming agents or the use of enemas may be needed. Skin assessment. The clean surgical wound heals at skin level in about 2 weeks in the absence of trauma, connective tissue disease, malnutrition, or the use of some drugs, such as steroids. Smokers and patients who are older, obese, or diabetic, or whose immunity is reduced, have delayed wound healing. Complete healing of all tissue layers within the surgical wound may take 6 months to 2 years. The physical health and age of the patient, size and location of the wound, and stress on the wound all affect healing time. Head and facial wounds heal more quickly than abdominal and leg wounds because of the better blood flow to the head and neck. Table 18.3. Calculating nasogastric tube drainage. Formula. Drainage and collection device minus the amount of irrigant equals the true or actual amount of drainage. Example. A patient's drainage container was marked at 150 mils at 7 a.m. At 3 p.m., there were 525 mils in the container. During the nursing shift, the nurse instilled 30 mils of saline as an irrigant into the tube 4 times, as prescribed by the physician. So it would be 525 minus 150 equals 375 mils of drainage. 30 times 4 equals 120 mils of irrigant, so take 375 minus that 120, and you get 255 mils of actual drainage. Woo! Normal wound healing. During the few days of normal wound healing, the incised tissue regains blood supply and begins to bind together. Fibrin and a thin layer of epithelial cells seal the incision. After 1 to 4 days, epithelial cells continue growing in the fibrin, and strands of collagen begin to fill in the wound gaps. This process continues for 2 to 3 weeks. At that time, the wound appears to be healed. However, healing is not complete for up to 2 years until the scar is strengthened. See Chapter 26 for a discussion of wound healing and wound infection. When the patient is an inpatient, the surgeon usually removes the original dressing on the first or second day after surgery. Assess the incision on a regular basis, at least every 8 hours, for redness, increased warmth, swelling, tenderness, or pain, and the type and amount of drainage. Some drainage, changing from sanguineous or bloody to serosanguineous to serous, serum-like or yellow, is normal during the first few days. Serosanguineous drainage continuing beyond the 5th day after surgery or increasing in amount instead of decreasing alerts you to the possibility of dehiscence, discussed below, and the surgeon should be notified. Crusting on the incision line is normal, as is a pink color to the line itself, which is caused by inflammation from the surgical procedure. Slight swelling under the sutures or staples is also normal. Redness or swelling of or around the incision line, excessive tenderness or pain on palpation, and purulent or odorous drainage indicates wound infection and must be reported to the surgeon. Ineffective wound healing. Ineffective wound healing may be caused by infection, distension from edema, or paralytic ileus, stress at the surgical site, and health problems that cause delayed wound healing, e.g. diabetes. Wound dehiscence is a partial or complete separation of the outer wound layers, sometimes described as a splitting open of the wound. Evisceration is the total separation of all wound layers and protrusion of internal organs through the open wound, figure 18.2. Both of these problems occur most often between the 5th and 10th days after surgery. Wound separation occurs more often in obese patients and those with diabetes, immune deficiency, or malnutrition, or who are using steroids. Dehiscence or evisceration may follow forceful coughing, vomiting, or straining, and when not splinting the surgical site during movement. The patient may state, "Something gave way," or "I feel as if I just split open." Dressings and drains. Assess all dressings, including casts and elastic or ACE bandages, for bleeding or other drainage on admission to the PACU, and then hourly thereafter. When the patient is on the nursing unit, assess the dressing each time vital signs are taken, at least every 8 hours. During dressing inspection, check for drainage and record its amount, color, consistency, and odor. If drainage is present on a dressing or cast, monitor its progression by outlining it with a pen and indicating the date and time. Check the area underneath the patient also, because drainage or blood may leak from the side of the dressing and not appear on the dressing itself. Ensure that the dressing does not restrict circulation or sensation. This problem is most likely to occur when dressings are tight or completely surround an arm or a leg. Chest dressings that are too tight or that encircle the chest can restrict breathing. The surgeon inserts a drain into or close to the wound if more than a minimal amount of drainage is expected. A Penrose drain, a single lumen soft open latex tube, is a gravity-type drain under the dressing. Drainage on the dressing is expected with open tube drains, but is not expected with closed drainage systems. Assess closed suction drains, such as a Hemovac or a VacuDrain, and a Jackson-Pratt drains for maintenance of suction. Specialty drains, such as a T-tube, may be placed for specific drain purposes. For example, a T-tube drains bile after a cholecystectomy. Figure 18.3 shows commonly used drains. Assess all drains for patency when the patient is admitted to the PACU and every time vital signs are taken. Monitor the amount, color, and type of drainage while the patient is in the PACU and at least every 8 hours after he or she is transferred to the medical surgical unit. Large amounts of sanguineous drainage may indicate internal bleeding. Discomfort/pain assessment. The patient almost always has pain or discomfort after surgery. Pain is a subjective experience and may be more intense than the healthcare professional can appreciate. Pain after surgery is related to the surgical wound, tissue manipulation, drains, positioning during surgery, presence of an ET tube, and the patient's experience with pain. In assessing his or her discomfort and need for medication, consider the type, extent, and length of surgical procedure. Assess for physical and emotional signs of acute pain, such as increased pulse and blood pressure, increased respiratory rate, profuse sweating, restlessness, confusion in the older adult, wincing, moaning, and crying. When possible, ask the patient to rate the pain before and after drugs are given, e.g. on a scale of 1 to 10, with 1 being no pain, 10 being extreme pain. Plan the patient's activities around the timing of analgesia to improve mobility. Observe for a return of normal baseline physical behaviors. See Chapter 5 for further discussion of pain assessment. Figure 18.3 shows the different types of drains, which include Penrose, T-tube, Jackson-Pratt, and the Hemovac. Pain assessment is started by the PACU nurse. After the patient is transferred from the PACU, the medical surgical nurse continues to assess the patient's comfort level. Pain usually reaches its peak on the second day after surgery, when the patient is more awake and more active and the anesthetic agents and drugs given during surgery have been excreted. Psychosocial assessment. Consider the psychological, social, and cultural issues of the patient after surgery as you provide physical care. This assessment may be delayed or difficult to perform in the PACU when the patient is drowsy or confused. Consider the patient's age and medical history, the surgical procedure, and the impact of surgery on recovery, body image, roles, and lifestyle. Physical signs of anxiety include restlessness, increased pulse, blood pressure, and respiratory rate, and crying. The patient may be anxious and ask questions about the results or findings of the surgical procedure. Reassure the patient that the surgeon will speak with him or her after he or she is fully awake. If the surgeon has already spoken with the patient, reinforce what was said. After the patient returns to the medical surgical unit, continue the psychosocial assessment and also assess significant others for psychological discomfort. NCLEX examination challenge. The client who had abdominal surgery for colon cancer is transferred to the medical surgical unit after 4 hours in the PACU. The nurse notes all the following assessment findings. For which one should the nurse notify the surgeon, anesthesia provider, or rapid response team? A. There is a large amount of serosanguine drainage on the dressing around the ostomy stoma. B. SpO2 is 80% when measured by pulse oximetry on the fingers, nose, and ear. C. The client is confused in trying to pull out the nasogastric tube. D. Bowel sounds are absent in all 4 abdominal quadrants. I think it's B, but yeah, it's probably B. Not sure though. Have to check. Laboratory assessment. Laboratory tests are performed after surgery to monitor for complications. Tests are based on the surgical procedure, the patient's medical history, and the clinical manifestations after surgery. Common tests include analysis of electrolytes and a complete blood count. See Chart 16.3 in Chapter 16. A change in laboratory test results, e.g. electrolyte, hematocrit, hemoglobin levels, often occurs during the first 24 to 48 hours after surgery because of blood and fluid loss and the body's reaction to the surgical process. Fluid loss with minimal blood loss may cause hemoconcentration of laboratory values. Such tests results are reported as increased but actually represent a concentrated normal value. An indication of infection is an increase in the band cells, immature neutrophils, in the white blood cell differential count. This increase is termed a left shift, sometimes called bandemia. The source of infection may be the respiratory system, urinary tract, wound, or IV site. Obtain specimens for culture and sensitivity testing, and monitor for culture reports at 24, 48, and 72 hours. Notify the surgeon of positive culture results. See Chapter 19 and 25 for information on infection and assessment of immune function. Arterial blood gas tests may be needed for patients who have respiratory or cardiac disease, those undergoing mechanical ventilation after surgery, and those who had chest surgery. Review ABG results and notify the surgeon of any acid-base imbalance or hypoxemia. For more discussion on arterial blood gases and acidosis, see Chapter 14. Urine and renal laboratory tests also may be obtained, e.g. urinalysis, urine electrolyte levels, and serum creatinine levels, or creatinine levels. Other laboratory tests depend on the diagnosis, type of surgical procedure, and other health problems. Examples are serum amylase level for a patient who had pancreatic surgery and a blood glucose level for a patient with diabetes. Decision-making challenge, critical rescue. The patient is a 32-year-old woman who is returned to the day surgery area after a tubal ligation performed by laparoscopic surgery. While you are assessing her, she tells you that her left shoulder really hurts and that she is nauseated. Her vital signs are as follows: heart rate 110, BPM, or beats per minute, blood pressure 90/68, rests 24. Her last vital signs recorded before leaving the OR were heart rate 90, BP 128/82, and rest 14. She received morphine sulfate 4 milligrams IV 20 minutes ago. 1. What additional assessment data should you obtain? 2. Should you assess for hemorrhage? 3. What are the possible causes for her left shoulder pain? 4. What is the most likely cause for her change in vital signs? 5. Should the surgeon be notified? Why or why not? Okay, analysis. Common nursing diagnoses and collaborative problems. Priority nursing diagnoses for the patient after surgery are impaired gas exchange, related to the effects of anesthesia, pain, opioid analgesics, and immobility. 2. Impaired skin integrity related to surgical wounds, decreased mobility, drains, and drainage in tubes. 3. Acute pain related to the surgical incision, positioning during surgery, and endotracheal tube irritation. A common collaborative problem is potential for hypoxemia. Additional nursing diagnoses and collaborative problems. In addition to the common nursing diagnoses and collaborative problems, patients may have one or more of these problems after surgery. Risk for aspiration related to decreased mobility, anesthesia, and opioid analgesic use, ineffective airway clearance related to ineffective or absent cough, and constipation related to decreased mobility, anesthesia, and opioid analgesic use. Also risk for infection related to surgery and invasive lines, catheters, and tubes. Risk or urinary retention related to anesthesia, surgical procedures, and decreased mobility. Delayed surgical recovery related to presence of other health problems, diabetes, obesity, or complications of surgery. Bathing, hygiene, self-care deficit related to surgical procedures, pain, and decreased mobility. Disturbed body image related to surgical procedures, loss of body part or function, and pain. Interrupted family processes related to the impact of surgery and illness or the family system. Potential for hypovolemic shock. Potential for deep vein thrombosis and pulmonary embolism. Planning and implementation. Impaired gas exchange. NOC planning expected outcomes. The patient is expected to attain or maintain optimal lung expansion and breathing patterns after surgery as indicated by partial pressure of arterial oxygen, PaO2, within normal range, partial pressure of arterial carbon dioxide, PaCO2, within normal range, oxygen saturation values within normal range. Interventions. Airway maintenance. After assessing the airway, you may need to insert an oral airway if the patient does not already have one. The oral airway pulls the tongue forward and holds it down to prevent obstruction. If the patient had oral surgery or has clenched teeth, a large tongue, or upper airway obstruction, insert a nasal airway, called a nasal trumpet, to keep the airway open. Keep the manual resuscitation bag and emergency equipment for intubation or tracheostomy nearby. For patients whose only airway is a tracheostomy or laryngectomy, stoma, alert other staff members by posting signs in the room and notes on the chart. Positioning. In the PACU, immediately position the patient in a side-lying position or turn his or her head to the side to prevent aspiration. Suction the mouth, nose, and throat to keep the airway clear of mucus or vomitus as needed. Keep the patient's head flat to prevent hypotension and possible shock, unless this position is contraindicated by the condition or surgical procedure. For example, after intracranial surgery, the head of the bed or stretcher is elevated to promote ventilation and prevent cerebral edema. Apply oxygen by face tent, nasal cannula, or mask to eliminate inhaled anesthetic agents. Increase oxygen levels, raise the level of consciousness, and reduce confusion. After the patient is fully reactive and stable, raise the head of the bed to promote respiratory function. Breathing exercises. After the patient regains the gag and cough reflexes and meets the agency's criteria for extubation, if intubated, remove the airway or ET tube. Usually extubation criteria are the ability to raise and hold the head up and evidence of thoracic breathing. Help the patient cough with the incision splinted and deep breathe to expand the lungs. Promote gas exchange and eliminate inhalation anesthetic agents. Chart 16.5 in Chapter 16 reviews breathing exercises and splinting of the surgical area. As soon as the patient is awake enough to follow commands, urge him or her to cough. Use the incentive spirometer and take deep breaths. Remind him or her to continue these activities throughout the postoperative period. The patient who is unable to remove mucus or sputum requires oral or nasal suctioning. Perform mouth care after removing secretions. Movement. Assist the patient out of bed and to ambulate as soon as possible to help remove secretions and promote lung expansion. Even when the patient has had extensive surgery, the goal may be to get out of bed the day of or the first day after surgery. If this is not possible, assist him or her to turn at least every 2 hours, side to side, and ensure that breathing exercises and leg exercises are performed. See charts 16.5 and 16.6 in Chapter 16. Early ambulation reduces the risk for pulmonary complications, especially after abdominal, pelvic, or spinal surgery. The patient may report pain and resist getting up, but you should stress the importance of activity to prevent complications. When indicated, offer pain medication 30 to 40 minutes before he or she gets out of bed. Impaired skin integrity, NOC, planning, expected outcomes. The patient is expected to have incision healing without wound complications as indicated by wound edges remaining together, absence of purulent drainage, induration, or redness in, from, or around the incision. Interventions. Nursing assessment of the surgical area is critical. See the discussion of skin assessment on page 291. Although most wound complications do not require additional surgery, emergency surgical procedures may be needed. Non-surgical management. Wound care includes reinforcing the dressing, changing the dressing, assessing the wound for healing and infection, and caring for drains, including emptying drainage containers, reservoirs, and measuring and documenting drainage. Emphasize the importance of early deep breathing exercises to prevent forceful coughing. Encourage hip flexion when the patient is in the supine position to reduce tension on a chest or abdominal wound. Remind the patient to always splint the incision when coughing. Promote wound healing and protection of the skin in general, especially for the older patient. Chart 18.3 lists the best practices for skin care of the older patient after surgery. Dressings. The surgeon usually performs the first dressing change to assess the wound, remove any packing, and advance pull partially out or remove drains. Before the first dressing change, reinforce the dressing. Add more dressing material to the existing dressing if it becomes wet from drainage. Document the added material as well as the color, type, amount, odor of drainage, fluid, and time of observation. Assess the surgical site at least every shift and report any unexpected findings to the surgeon. After removal of the dressing, the surgeon may leave the suture or staple line open to the air, which allows easy assessment of the wound and early detection of poor wound edge adherence, drainage, swelling, or redness. Some surgeons believe that air drying promotes healing. A draining wound, however, is always covered with a dressing. Really? Dressing changes are prescribed by the surgeon. However, the facility or unit may have standards or policies that dictate specific protocols for dressing changes and incision care. An unchanged wet or damp dressing is a source of infection. Change dressings using aseptic technique until the sutures or staples are removed. Dressings may vary with the surgical procedure and the surgeon's preference. Common dressings for large incisions consist of gauze or non-adherent pads covered with a large absorbent pad held in place by tape, a tubular stretchy net or Montgomery straps, figure 18.4. Some incisions may be covered with a transparent plastic surgical dressing, e.g. OpSite, or a spray in the operating room. This type of dressing stays intact for 3 to 6 days and allows direct observation of the wound. It also prevents contamination and eliminates the need for dressing changes. Chart 18.3. Nursing focus on the older adult. Best practice in postoperative skin care. Improve perfusion to the wound to promote wound healing. Keep the patient adequately hydrated to maintain cardiac output. Keep the airway patent and provide adequate oxygenation. Keep the patient's oxygen saturation on pulse oximetry at greater than 93%. Now, conserve the patient's energy as an outcome. Allow the patient to sleep in a darkened, quiet room. Administer drugs to combat pain and sleeplessness as prescribed, and provide rest periods throughout the day. Also, control the patient's room temperature and assist in ADLs. Next, put the patient on a safety program to prevent falls if indicated. Use strict aseptic technique in caring for breaks in the integument, e.g. IV or catheters, indwelling urinary urethral catheters, or the wound. Maintain the patient's psychosocial health. Interventions would be prevent unnecessary stressors, allow the patient liberal visitation of supportive others, enable the patient to use individual successful coping mechanisms, and keep the patient well groomed and bathed. Next is protect fragile skin. Interventions: minimize the use of tape on the skin, use hypoallergenic tape or Montgomery straps, change dressings as soon as they become wet, and lift the patient during transfer or repositioning. Back to the text. Wound or suture line care consists of changing gauze dressings at least once during a nursing shift or daily, and may include cleaning the area with sterile saline or some other solution. Some suture lines are left open to the air without any dressing to cover the incision. The hospital's policy, the unit's standards, and the surgeon's preference determine what solution, if any, is used to clean the wound and how often dressings are changed. For large dressing changes or drainage removal, offer the patient a prescribed analgesic before the procedure. Also, assess the skin for redness, rash, or blisters in areas where tape has been used. Tape can cause a skin reaction after surgery, even among patients who are not known to be tape sensitive. Skin sutures or staples are usually removed 6 to 8 days after surgery, and the incision is secured with steri strips. The surgeon or the nurse removes the sutures or staples depending on the agency's policy. Clean the incision before removing sutures or staples. Before removing sutures, examine the condition and healing stage of the wound. First remove every other suture or staple and reassess the wound for integrity. If wound healing is progressing normally, the rest of the sutures or staples may then be removed, or may be removed the next day. If the wound does not appear to be healing well, notify the surgeon before removing any sutures. Drains. See Figure 18.3. Drains may be placed in the wound or through a separate small incision known as a stab wound, close to the incision during surgery. Drains provide an exit route for air, blood, and bile. Drains also help prevent deep infections and abscess formation during healing. The Penrose drain is placed into the external aspect of the incision and drains directly into the dressing and skin around the incision. Change a damp or soiled dressing and carefully clean under and around the Penrose drain. Then place absorbent pads under and around the exposed drain to prevent skin irritation and wound contamination. Whether sutured in place or not, the drain can be dislodged or pulled out accidentally during a dressing change. It is also possible for the drain to slip back through the wound into the patient. Usually this complication is prevented when the drain is first placed in the OR. The surgeon pins a sterile safety pin through the drain at an angle perpendicular to the drain and the wound. The safety pin acts as a barrier to prevent the drain from slipping. As the wound heals, the surgeon or nurse shortens or advances the drain by pulling it out a short distance and draining off the excess external portion so that only 2 to 3 inches of drain protrudes through the incision. The stabilizing safety pin must be repositioned each time the drain is advanced. The drain remains in place until drainage stops. Jackson Pratt and Hemovac drains are 2 self-contained drainage systems that drain wounds directly through a tube via gravity and vacuum. These drains are sutured in place with a suture that seals the area when the drain is removed. Excuse me. Use sterile technique to remove the reservoir. Record the amount and color of drainage during every nursing shift, or more often if prescribed. After emptying and compressing the reservoir to restore suction, secure the drain to the patient's gown, never to the sheet or mattress, to prevent pulling and stress on the surgical wound. Drug therapy. Wound infection is a major complication after surgery. It usually results from contamination during surgery, preoperative infection, debilitating debilitation, or immunosuppression. A patient at risk for wound infection may receive antibiotic therapy with drugs that are effective against organisms common to a specific surgical site. These antibiotics are usually continued for at least 24 hours after surgery. The first dose may be given IV before or during surgery. Wounds that become infected and open are treated with dressing changes and systemic antibiotic therapy. Depending on the surgeon's prescription, irrigate the wound, e.g. the sterile saline, hydrogen peroxide, povidone, iodine, or acetic acid. Loosely pack it with solution-soaked gauze, e.g. neomycin, gentamicin, iodoform, povidone, iodine, saline, or acetic acid, and cover the wound with dry, sterile dressings. This procedure, wet to damp dressings, may be done 1 to 3 times daily. The packing promotes healing from within the wound and debridement, or removal of the infected or dead tissue, as the wound heals. Surgical management. Poorly healing wounds, infected wounds, or complicated wounds may require surgical intervention. That's all it says. Management of dehiscence. If dehiscence, or wound opening, occurs, apply a sterile non-adherent, e.g. telfa or saline dressing to the wound and notify the surgeon. Instruct the patient to bend the knees and to avoid coughing. A wound that becomes infected dehisces by itself, or it may be opened by the surgeon through an incision and drainage or an I&D procedure. In either case, the wound is left open rather than resutured and is treated as described previously. Management of evisceration. An evisceration, a wound opening with protrusion of internal organs, is a surgical emergency. One nurse tends to the patient while another nurse immediately identifies the surgeon or notifies the surgeon. Chart 18.4 lists best practices for emergency care of the patient with surgical wound evisceration. Provide emotional support by explaining what happened and reassuring the patient that the emergency will be handled completely. The surgeon may prescribe a nasogastric tube to determine the stomach and decompress the stomach and relieve internal pressure or remove the stomach's contents if the patient has been eating and general anesthesia is needed. Prepare the patient for surgery. See Chapter 16. To close the wound. Regional or local anesthesia may be used, depending on the location and type of wound. Nausea and vomiting, which stress the already fragile incision, are reduced when regional or local anesthesia is used. To increase the incision's integrity, stay or retention sutures or wire or nylon are used, along with standard sutures or staples. Prevention. Patients also at risk for developing pressure ulcers from positioning during surgery, prolonged contact with damp surgical lines, and contact with unpadded surfaces. Pressure ulcers acquired during the surgical period increase lengths of stay and the risk for complications. Addressing early-stage pressure ulcers can prevent progression and limit complications. Examine the patient's skin for areas of redness or open areas. Document and report any abnormalities. Use padding and positioning to relieve pressure. Treat any open areas according to facility guidelines and the surgeon's prescription. Ensure that information about the patient's skin condition in the PACU is communicated to the medical surgical nurse. Decision-making challenge. Coordination of care. The patient is a 52-year-old obese woman who had abdominal surgery 4 days ago for an ovarian abscess. She takes Avandia for type 2 diabetes and prednisone 10 milligrams daily for rheumatoid arthritis. She is still on IV antibiotics and has been very adherent to her postoperative prevention regimen. She walks unassisted several times a day in the hallway, drinks 4 liters of water each day, and uses her incentive spirometer every 2 hours while she is awake. When you make your rounds at midnight, she is awake and tells you that she has felt incision pressure all day, but when she climbed back into bed a few minutes ago, she felt something pop, and now the pressure is gone. When you look under her loose dressing, you see loops of bowel protruding. You are the only registered nurse on this small 12-bed unit, and you have one LPN and one unlicensed nursing assistant working with you. What is your first action? 2. Who should stay with the patient, you, the LPN, or the nursing assistant? Why? 3. Who should be notified first, the surgeon or the rapid response team? Provide rationale for your answer. 4. What risk factors does this patient have for impaired wound healing and evisceration? 5. Would it have been better for this patient to stay in bed rather than ambulate? And 6. Could anything have been done to prevent this complication? Chart 18.4, Best Practices for Patient Safety and Quality Care. Emergency care of the patient with surgical wound evisceration. 1. Call for help. Instruct the person who responds to notify the surgeon or rapid response team immediately and to bring any needed supplies into the patient's room. 2. Stay with the patient. 3. Cover the wound with a non-adherent dressing pre-moistened with warmed sterile normal saline. Note, the supplies needed for this emergency should be in the patient's room, especially if the patient is at high risk. 4. If pre-moistened dressings are not available, moisten sterile gauze or sterile towels in a sterile irrigation tray with sterile saline and then cover the wound. 5. If saline is not immediately available, cover the wound with gauze and then moisten with sterile saline using a sterile irrigation tray as soon as someone brings saline. 6. Do not attempt to reinsert the protruding organ or viscera. 7. While covering the wound, note the patient's response and assess for manifestations of shock. 8. Place the patient in a supine position with the hips and knees bent. 9. Raise the head of the bed 15 to 20 degrees. 10. Take vital signs and document them. Note if the person who answered the call for help is back in the room before this, instruct him or her to take vital signs while you focus on covering the wound and repositioning the patient. 11. Provide support and reassurance to the patient. 12. Continue assessing the patient, including vital signs assessment every 5 to 10 minutes until the surgeon arrives. 13. Keep dressings continuously moist by adding warmed sterile saline to the dressing as often as needed. Do not let the dressing become dry. When the surgeon arrives, report your finding and your interventions, then follow the surgeon's directions. Document the incident, the activity the patient was engaged in at the time of the incident, your actions, and your assessments. Acute pain, knock, planning expected outcomes. The postoperative patient is expected to attain or maintain optimal comfort levels. Indicators include reporting that pain is controlled, absence of physiologic indicators of acute pain, like increased heart rate and blood pressure, absence of facial grimacing, teeth clenching, willingness to move and participate in self-care. Interventions. Pain management after surgery includes drug therapy and other methods of management, such as positioning, massage, relaxation techniques, and diversion. Often the patient has better pain relief from a combination of approaches. Assess the patient's comfort level and the effectiveness of the therapies. See Chapter 5 for discussion of pain assessment and management. The patient who has optimal pain control is better able to cooperate with the therapies and exercises to prevent complications and promote rehabilitation. Drug therapy. The use of opioids or other analgesics for pain management may mask or increase the severity of symptoms of an anesthesia reaction. Therefore, give these drugs with caution, especially in the PACU when the patient's condition is not stable. When the pain drugs are used in the PACU, they are usually given IV in small doses. After receiving any drug for pain, the patient remains in the PACU for a defined period, often 45 to 60 minutes. Assess for hypotension, respiratory depression, and other side effects. Within 5 to 10 minutes after an IV injection, assess the effectiveness of the drug, i.e. on a rating scale, in relieving pain. Opioid analgesics are given during the first 24 to 48 hours after surgery to control acute pain. Round-the-clock scheduling is more effective than on-demand scheduling because more constant blood levels are achieved. Round-the-clock scheduling is more effective than on-demand scheduling because more constant blood levels are achieved. Drugs commonly used include morphine or statics, hydromorphone or Dilaudid, ketorolac or Toradol, meperidine or Demerol, codeine, butorphanol or Stadol, and oxycodone with aspirin or Percodan, or oxycodone with acetaminophen, which is Psylox or Percocet. Assess the type, location, and intensity of the pain before and after giving medication. See also page 292 and 293 in the discomfort pain assessment section. Monitor the patient's vital signs for hypotension and hypoventilation after giving opioid drugs. Chapter 18.5 lists more information about analgesics used after surgery. Patient-controlled analgesia, PCA, by IV infusion or internal pump. The catheter is sutured into or near the surgical area, and epidural analgesia are often used for better pain control. In PCA, or once again patient-controlled analgesia, the patient adjusts the dosage of the analgesic on the basis of the pain level and responses to the drug. This method allows more consistent pain relief and more control by the patient. The maximum dose per hour is locked in to the pump so that the patient cannot accidentally overdose. Drugs given by the PCA method include morphine, meperidine, and hydromorphone. Epidural analgesia can be given intermittently by the anesthesia provider or by continuous drip through an epidural catheter left in place after epidural anesthesia. Drugs given by epidural catheter include the opioids fentanyl or Sublimase, preservation-free morphine or Duramorph, and bupivacaine or Marcaine. Take care not to over-medicate or under-medicate, especially with older patients. And assessing for over-medication, monitor vital signs, especially blood pressure and respiratory rate and level of consciousness. Complications from the use of opioid analgesics include respiratory depression, hypotension, nausea, vomiting, and constipation. And opioid antagonists such as naloxone or Narcan may be needed to reverse the acute effects of opioid depression. Because of the short effect of the opioid antagonists, monitor the patient's blood pressure and the respirations every 15 to 30 minutes until the full effect of the opioid analgesic has passed. You may need to give more doses of the antagonist during this time because it is eliminated from the body more quickly than is the opioid. See Chart 18.6 for more information on using opioid antagonists to reverse opioid overdose. In addition, the patient has breakthrough pain after the opioid antagonist is given, so other interventions to promote comfort are needed. Chart 18.5 common examples of drug therapy, management of postoperative pain. Drug morphine sulfate. Drug morphine sulfate, 2 to 15 milligrams IM or IV. Monitor respiratory status, and respiratory depression can be severe and require medical intervention. Epimorph, incrementally is the dosage, and monitor blood pressure. Statics, 10 to 30 milligrams orally every 4 hours. Assess for GI motility and urine output. Monitor blood pressure. Hypertension, constipation, and urinary retention can occur. Med-air alert. Watch the Dosage. The dosage of morphine is only 1/10 that of meperidine, hydromorphone, hydrochloride, or Dilaudid. I'm sorry, no. Yeah, morphine is only 1/10 of meperidine. Okay, then on to hydromorphone or hydrochloride Dilaudid. 1 to 4 milligrams IV or IM every 3 to 4 hours. Monitor respirations, monitor blood pressure, monitor for food intolerance, monitor fluid and electrolyte balance, assess GI motility. Respiratory depression, hypotension, anorexia, nausea, vomiting, and constipation can occur. Med-error alert on this one. Watch dosage. Dosage of hydromorphone is only 1/10 out of morphine. Okay. And meperidine hydrochloride, 50 to 100 milligrams orally or IM every 3 to 4 hours. Monitor blood pressure. Move and ambulate the patient slowly. Monitor pulse rate. Assess for decreased motility or upset of GI. Common side effects include decreased blood pressure, orthostatic postural hypertension, and bradycardia. Constipation, nausea, and vomiting can occur. Then there's codeine sulfate or Paverol, 15 to 60 milligrams IM or orally every 4 hours, maximum 6 doses. Monitor respiratory status, monitor for food intolerance, monitor fluid and electrolyte imbalance, and assess GI motility. Respiratory depression, nausea, and vomiting can occur. Constipation is common. Prophylactic interventions may be indicated. Butorphanol tartrate or Statol. That's 1 to 4 milligrams IM every 3 to 4 hours, 0.5 to 2 milligram IV, maximum 6 to 8 doses. Monitor neurologic status and changes in level of consciousness. Monitor respiratory status. Butorphanol can cause increased intracranial pressure and respiratory depression. Oxycodone, hydrochloride, and aspirin, Percodan, and Endocan, and oxycodone. 1 to 2 tablets, 5 to 10 milligrams orally every 3 to 4 hours, maximum 80 milligrams. Assess GI tolerance of medication, assess for GI bleeding, assess GI motility, monitor coagulation studies, PT and APTT, and monitor respiratory status. The aspirin component can irritate the stomach and could cause GI bleeding. Bleeding times in other coagulation studies results may be increased because of the aspirin component, and respiratory depression and constipation can be caused by the oxycodone component. Oxycodone hydrochloride and acetaminophen, Endocet, Oxycocet, Tylox, and Percocet. 1 to 2 tablets, 5 to 10 milligrams orally every 3 to 4 hours, maximum 12 tablets. Monitor blood pressure and respiratory status. Assess for GI motility. Respiratory depression, hypotension, and constipation can occur. Okay. Ketorolac, tromethamine, or Toradol. 15 to 60 milligrams IM or IV every 6 hours. Maximum 120 milligrams. Monitor for GI bleeding. Monitor for renal effects, especially in older adults. GI bleeding, ulceration, and perforation can occur. Decreased urine output, increased serum creatinine, hematuria, and proteinuria can occur. Ketorolac is cleared more slowly in older adults, and older persons are more sensitive to the renal effects of NSAIDs. Med alert for Toradol is do not confuse Toradol with Tramadol, a drug used for central analgesia. Ibuprofen, Motrin, Amersol, Novaprofen. 300 to 800 milligrams orally every 4 to 6 hours, maximum 240 milligrams daily. Monitored upper GI tolerance of medication. Give with food or milk. This is just ibuprofen. Monitor coagulation studies, PT and APTT. Assess for signs of bleeding or delayed clotting. Food or milk helps decrease irritation of the stomach. Bleeding times in other coagulation study results may be increased, and monitoring leads to early detection of complications. Back to the text. Assess for undermedication by asking the patient about the effects of the drug and observing for nonverbal cues of pain or discomfort, e.g., restlessness, increased confusion, picking at bed covers, aggressive behaviors. Offer prescribed pain drugs after checking for hypotension and respiratory depression. As recovery progresses, reduce the doses and frequency of pain drugs. Drugs are changed from injectable or PCA to oral as soon as the patient can tolerate oral agents. Non-opioid analgesics such as acetaminophen or Tylenol, Atazol, and non-steroid anti-inflammatory drugs, NSAIDs, such as ibuprofen, Motra, Noviprofen, and Amersol, and ketorolac or Toradol, are used alone or with opioid analgesics. Anti-anxiety drugs such as hydroxyzine or Vistaril, Novahydroxin, may be given with an opioid analgesic. This combination decreases pain-related anxiety, reduces muscle tension, and controls nausea. Chart 18.6, best practice for patient safety and quality care. Emergency care of the patient experiencing an opioid overdose. Prepare to administer naloxone hydrochloride or Narcan in a dose of 1 to 2 milligrams IV. Repeat drug every 2 to 3 minutes up to 10 milligrams as needed depending on the patient's response. Maintain an open airway. Give oxygen if hypoxia is present or if respirations are below 10 breaths per minute. Have suction equipment available because Narcan can trigger vomiting and a drowsy patient is at risk for aspiration. Continuously monitor vital signs and level of consciousness for reversal of overdose. Do not leave the patient until he or she is fully responsive. Assess the patient for pain because reversal of the opioid overdose also reverses the analgesic effects. Continue to monitor the patient's vital signs and level of consciousness every 10 to 15 minutes for the first hour because Narcan is eliminated from the body more quickly than is the opioid, and because the antagonist may induce side effects including blood pressure changes, tachycardia, and dysrhythmias. Determine the need for additional antagonist therapy 1 hour after the patient initially becomes fully responsive. There are other opioid antagonists. However, Narcan is used most often to manage adult opioid overdose in the postoperative period. Complementary and alternative therapies. Provide other comfort measures that may lower the amount of pain drugs needed. These measures, such as positioning, massage, relaxation, and diversion, reduce anxiety and allow the patient to relax and rest. In positioning the patient, consider the position during surgery, the location of the surgical incision, and drains and problems such as arthritis and chronic lung disease. Assist the patient to a position of comfort. Support the extremities with pillows. Unless the surgeon prescribes pillow support, place no pillows under the knees and do not raise the knee gash, because this position could restrict circulation and increase the risk of thrombophlebitis. Turn or help the patient turn at least every 2 hours while he or she is bedridden to prevent complications caused by immobility. On the basis of the surgeon's prescription and your assessment of the patient's tolerance, urge the patient to increase activity progressively. Activity decreases stiffness, helps lung expansion, and promotes venous blood return. When he or she is first allowed out of bed, assist the patient to the side of the bed and into a chair. Teach him or her to splint the surgical wound for support and comfort during the transfer. Use gentle massage on stiff joints or sore back to decrease comfort. Assist the patient to a side-lying position and apply lotion with smooth, gentle strokes to increase blood flow to the area and promote relaxation. Do not massage the calves because of the risk of loosening a clot and causing a life-threatening pulmonary embolus. Alright, no massaging the calves. Chart 18.7, best practice for patient safety and quality care. Non-pharmacologic interventions to reduce postoperative pain and promote comfort. Control or remove noxious stimuli. Cushion and elevate painful areas. Avoid tension or pressure on those areas. Provide adequate rest to increase pain tolerance. Encourage the patient's ability or participation in diversional activities. Instruct the patient in relaxation techniques. Use audio tapes or CDs and breathing exercises. Provide opportunities for meditation. Help the patient stimulate sensory nerve endings near the painful areas to inhibit ascending pain impulses. Okay. Use ice to reduce and prevent swelling as indicated. Find a general position of comfort for the patient. Help the patient stimulate the area contralateral or opposite to the painful area. Relaxation and diversion are also used to control acute episodes of pain that may occur during the dressing changes and injections. Chapter 2 and 5 discuss how to instruct and guide the patient through these control methods. Music and noise reduction have also been shown to decrease awareness of discomfort. Chapter 18.7 lists other interventions that may help reduce pain and promote comfort. Potential for hypoxemia, NOC, planning expected outcomes. The patient is expected to attain or maintain preoperative baseline partial pressure of arterial oxygen PaO2 values. Intervention. The key to preventing hypoxemia is to follow the interventions for the nursing diagnosis of impaired gas exchange, ineffective airway clearance, and ineffective breathing pattern. After surgery, monitor the patient's oxygen saturation, SpO2, with pulse oximetry. An older adult is often prescribed to receive low-dose oxygen therapy for the first 12 to 24 hours after surgery to reduce confusion from anesthesia and sedation. A patient who received conscious sedation with a benzodiazepine, such as midazolam, or Versed, or lorazepam, Ativan, or Norloraz, may be overly sedated or have pulmonary depression sufficient to need reversal with flumazenil or romazicon. Chart 18.8. Hypothermia after surgery causes shivering that increases oxygen demand and can induce hypoxemia. Many rewarming methods can be used, although prevention is more important. The highest incidence of hypoxemia after surgery occurs on the second postoperative day. Patients who normally have a low PaO2, such as those with lung disease or older adults, are at higher risk for hypoxemia. Hypoxemia is treated with oxygen therapy. Depending on the surgeon's preference and established guidelines, oxygen therapy may continue through the second day after surgery. When hypoxemia occurs despite preventative care, interventions to manage the cause of the hypoxemia are prescribed. These may include respiratory treatments and mechanical ventilations if needed. Community-based care. Many patients are discharged after a brief hospital stay or directly from the PACU to home. Because of the shortened length of hospital stays, discharge, planning, teaching, and referral begin before surgery and continue after surgery. Chart 18.8, best practices for patient safety and quality care. Emergency care of the patient experiencing benzodiazepine overdose. Secure the airway and IV access before starting benzodiazepine antagonist therapy. Prepare to administer flumazenil or romazicon in a dose of 0.2 milligrams to 1 milligram IV. Repeat drug every 2 to 3 minutes, up to 3 milligrams as needed, depending on the patient's response. Give oxygen if hypoxia is present or if respirations are below 10 breaths per minute. Have suction equipment available because flumazenil can trigger vomiting and a drowsy patient is at risk for aspiration. Continuously monitor vital signs and levels of consciousness for reversal of overdose. Do not leave the patient until he or she is fully responsive. Continue to monitor the patient's vital signs and level of consciousness every 10 to 15 minutes for the first 2 hours because flumazenil is eliminated from the body more quickly than is the benzodiazepine. Determine the need for additional flumazenil therapy 1 to 2 hours after the patient initially becomes fully responsive. Observe the patient for tremors or convulsions because flumazenil can lower the seizure threshold in patients who have seizure disorders. Assess the IV site every shift because flumazenil can cause thrombophlebitis at the injection site. Observe the patient for side effects of flumazenil, including skin rash, hot flushes, dizziness, headache, sweating, dry mouth, and blurred vision. The incidence of these side effects increases with higher total doses of flumazenil. There are other benzodiazepine antagonists, however, flumazenil is used most often to manage adult benzodiazepine overdose in the post-operative period. Home care management. If the patient is discharged directly to home, assess information about the home environment for safety, cleanliness, and availability of caregivers. Use the database obtained on admission before surgery to determine the patient's needs. For example, if the patient is unable or not allowed to climb stairs and lives in a 2-story house with only 1 bathroom, advise the patient to rent a bedside commode. Collaborate with the social worker or discharge planner to identify needs related to care after surgery, including meal preparation, dressing changes, drain management, drug administration, physical therapy, and personal hygiene. A referral to a home care nurse agency may be included. The patient is usually concerned about complications, pain, changes in the usual activity level, or payment of the hospital bill. The more extensive the surgical procedure is, the more fearful the patient is of assuming self-care. Support the patient and family members as they need more emotional support from an acceptance of his or her family. The patient may be angry about the surgical outcome or about role changes. He or she may be concerned about financial matters and work. The surgical outcome may not have met the patient's expectations, and further interventions may be needed to assist in resolving his or her feelings. Ensure that referrals are made for additional counseling as indicated. Health teaching. The teaching plan for the patient and family after surgery includes prevention of infection, care and assessment of the surgical wound, management of drains or catheters, nutritional therapy, pain management, drug therapy, and progressive increase in activity. If dressing changes and drain or catheter care are needed, instruct the patient and family members on the importance of proper hand washing to prevent infection, Explain and demonstrate wound care if the patient and family who then perform a return demonstration. During teaching sessions, evaluate learning and promote adherence after discharge. At the same time, teach about the manifestations of complications such as wound infection. Also instruct the patient and family about what to do if complications occur. A diet high in protein, calories, and vitamin C promotes wound healing. Supplemental vitamin C, iron, zinc, and other vitamins are often prescribed after surgery to aid in wound healing and red blood cell formation. Instruct the patient who needs dietary restrictions about the importance of following the prescribed diet while recovering from surgery. Encourage the older adult or debilitated patient to continue using dietary supplements if prescribed between meals until the wound is completely healed and the energy levels are restored. Teach the patient about drugs for pain, especially about the proper dosage and frequency. Instruct the patient to notify the surgeon if pain is not controlled or if the pain suddenly increases. If antibiotics or other drugs are prescribed, stress the importance of completing the entire prescription. Surgery stresses the body and time and rest are needed for healing. Teach the patient to increase activity levels slowly, rest often, and avoid straining the wound or the surrounding area. The surgeon decides when the patient may climb stairs, return to work, drive, and resume other usual activities, such as sexual intercourse. The amount of weight that the patient can lift safely after surgery is specifically defined by the surgeon, i.e. in pounds or kilograms. Remind a patient of the weights of groceries, bags, women's handbags, laundry baskets, children, and books. Instruct the patient in the use of proper body mechanics. A patient whose work involves a moderate amount of physical labor may return to work about 6 weeks after abdominal surgery. However, he or she may be eager to return to normal activities and may not follow restrictions. Stress the importance of adherence to prevent complications or disability. The patient must receive written discharge instructions to follow at home. A referral for a home nurse may be needed for follow-up. Healthcare resources. After returning home, the patient may need equipment and assistance with dressing changes, ADLs, and meal preparation. Referral to a home care agency is made if needed. Home care may be paid for by third-party insurance payers, including Medicare, if the patient is homebound and requires skilled care such as dressing changes or physical therapy. The home care nurse provides skilled nursing assessments, dressing supplies, education and self-care, and referrals for services as needed. Such referrals include Meals on Wheels, support groups, and homemaker services, e.g. for housekeeping, food shopping. Evaluation outcomes. Evaluate the care of the patient after surgery on the basis of the identified nursing diagnosis and collaborative problems. The expected outcomes include that the patient attains and maintains adequate lung expansion and respiratory function, has complete wound healing without complications, has acceptable comfort levels after surgery. Specific indicators for these outcomes are listed for each nursing diagnosis, and its collaborative problem in the planning and implementation sections see earlier. Get ready for NCLEX examination. Key points. Review these key points for each NCLEX examination client needs category. Safe and effective care environment. Use aseptic technique during all dressing changes. Use established criteria to determine when a patient is ready to leave the post-anesthesia care unit, or PACU, for discharge to home or a medical surgical unit. Keep suction equipment, oxygen, and artificial breathing equipment near the patient in the PACU. Health promotion and Maintenance. Reinforce to the patient after surgery the specific interventions to use to prevent complications. Incision splinting, deep breathing exercises, range of motion exercises, as described in Chart 16.6 and Chapter 16. Encourage early ambulation. Stress the need for following the activity restrictions prescribed by the surgeon. Psychosocial integrity. Explain all procedures, restrictions, drugs, and follow-up care to the patient and family. Allow the patient to verbalize feelings about any change in physical appearance or lifestyle as a result of surgery. Reassure patients that taking pain medication when needed, even opioids, does not make them drug abusers. Remain with the patient if wound dehiscence or evisceration occurs. Offer alternative therapies for relaxation, pain reduction, and distraction, such as massage, music therapy, and guided imagery. Physiological integrity. Begin every assessment of the patient after surgery by checking the airway and breathing effectiveness. Assess the incision site each shift on the medical surgical nursing unit. In the event of wound dehiscence or evisceration, have the patient lie flat, supine, with knees bent to reduce intra-abdominal pressure. Apply sterile, non-adherent dressing materials to the wound, and follow the steps outlined in Chart 18.4. Teach the patient about any drugs to be continued after discharge from the facility, and instruct the patient and family about the clinical manifestations of complications and when to seek assistance. All right, and that's Chapter 18, Care of Postoperative Patients.